Well, I know that we'll probably still have some people join us, but also know we have a lot to cover today. So wanted to go ahead and get us started. Wanted to remind everyone that either you can use your right click and rename yourself uh, on your name, on your little screen with your name. Or if you would like to enter your name and organization in the chat, for anyone that's seeking a certificate of attendance to use for the continuing education hours, we need that information because often it has information that we can't link to the person who registered for the series. So if you would, excuse me, please go ahead with that and we'll make sure to get you certificates of registration of attendance, excuse me, as soon as we can. We've been doing those on a once monthly basis just because this is an ongoing series. I wanted to introduce Rochelle Martin, who has been leading the series for us, and we really appreciate. And we're really pleased today to be able to focus, as we have in previous sessions, on a specific area. And today, really focusing specifically on FQHCs and rural health clinics, which have very specific cost-based or cost-adjacent, I sometimes say, billing structures. So with that, I will hand things off to Rochelle and let her get started. Thanks again for being here today. We really hope you'll find today's session beneficial.
Right, thanks, Robert. And I'm going to jump in pretty quickly to the content as well, because as we're going to see with rural health clinics and FQHCs, a lot of the concepts on how to complete the claim form are similar with just slight differences between the two facility types. And what I'm going to focus on this afternoon are the Medicare claims submission requirements for FQHCs and RHCs. However, I am going to talk about some of the Medicaid specific rules in Kansas, Missouri, and Oklahoma as well. And with Medicare, we're focused on the UB04, or sometimes called the CMS 1450 claim form, or its electronic equivalent. So we're going to take what it would look like in paper format and look at that claim form in specific fields and instructions for when and where and how to complete those fields for Medicare, and then talk about some of the differences that we'll see with the three Medicaid agencies. And then also some telehealth specific and COVID telehealth specific billing rules as we go through this. One thing I did want to mention that I was talking to Robert and Christy about right before we got started is we're going to be in a pretty critical time period. I think in the next 30 to 45 days or so, we're starting to see states roll back their state emergency declarations. So as of right now, we still have the public health emergency at a national level, which continues to allow us a lot of the telehealth flexibilities through the end of the federal public health emergency, and some of those through the end of at least the calendar year when that ends. So as of right now, December 31st of this year, some of the state flexibilities and state Medicaid rules and licensing rules for providers, we may start to see those roll back, which can affect how we're billing for telehealth with commercial payers and Medicaid in each state, and could potentially affect how we bill for Medicare telehealth services, because Medicare's flexibilities allow us to do things for payment for Medicare, but from a licensing perspective, still defer back to state law. So if our state law flexibilities are changing, it may also affect how we're dealing with Medicare, even though the federal public health emergency continues to exist. So right now, some important dates to keep in mind for Missouri: their state declaration comes up for renewal June 15th. Oklahoma, last week was a big week for you because May 4th, I think was Tuesday, the state emergency declaration was rescinded. As of this morning, I don't see any major changes to telehealth policies in Oklahoma. Oklahoma was one of the states that said we're going to be reevaluating when and if the emergency status ends. So that's something we'll want to be keeping an eye on. And then in Kansas, May 28th is a date that we're going to want to keep an eye on to see whether our state's emergency declaration will be renewed or whether it will expire. So in this slide, I've got a couple of links. When I send the slides out, you'll be able to follow these hyperlinks to some of the important references that I'm relying on in completing the claim form. So there's a claims processing manual for RHCs and FQHCs, the general claims processing manual for the UB04 or 1450 claim form, and then provider manuals for Kansas and Missouri Medicaid. Oklahoma is a little bit different because they don't have a comprehensive RHC FQHC manual, but they do have some helpful billing instructions that we'll go through. Okay, so Robert mentioned some of the nuances. If you're on this session, you may work with an RHC or FQHC and have some familiarity with these basic billing concepts. But one of the ways that RHCs and FQHCs are different than, say, a regular provider office is that rather being paid under more of a fee-for-service type model, generally, there's an all-inclusive encounter rate that is paid for these clinic types, these facility types, and with certain limited exceptions. So one of those exceptions that we're going to talk about with some interesting and kind of challenging billing nuances is in the situation that a patient may actually have two distinct encounters at the RHC or FQHC in a day. So the patient comes in the morning for one condition and maybe has to have a separate encounter for an injury that happened that day later in the afternoon, and ways that you can be paid for both of those encounters rather than just for one, including, as we'll talk about, if those are done via telehealth, or one's a medical visit and one's a mental health services visit. So we're going to have several really technical specific billing rules for that situation that would allow separate payment outside a single all-inclusive encounter rate. Now, generally, RHCs and FQHCs for Medicare are not allowed to serve as the distant site. So they can be an originating site where the patient is located and bill an originating site fee. Outside of some of the COVID flexibilities we've had, they're generally not allowed to be distant site. Right now, they are allowed to be distant site practitioners for telehealth services for Medicare, Kansas, Missouri, and Oklahoma Medicaid as well. Telehealth services are the only FQHC services that are subject to the Part B deductible under the Medicare program. And we should know that the technical components for services are still billed separately. And we'll look at how to do that in just a little bit. So I'm going to start with the top of the UB04 claim form and just kind of walk through some of the fields on the claim form and some of the digits or billing rules that come from Medicare's billing guidelines and some of the Medicaid billing guidelines. So the first thing in the top right-hand corner of the UB04 claim form is the type of bill. And one thing I wanted to mention on the type of bill is that technically this is a 4-digit number that goes here. The leading number is a 0. And so I noticed in the Medicaid manuals, they refer to 3 digits. So they're essentially ignoring the 0 and they count digit 2, where I've got a 7 here. They would call that the first digit. So there's a little bit different nomenclature depending on whether you're looking at Medicare or Medicaid manuals there. So for RHCs and FQHCs, that second digit or first digit, depending on which manual you're looking at, is a 7, followed by either a 1 or a 7, depending on whether you're an RHC or an FQHC. And then the last digit typically is going to be a 1. It establishes the frequency of the bill, like if this is the first bill, and that's typically going to be the case for RHCs and FQHCs. So on that 4th digit, or again, the Medicaid agencies might call it the 3rd digit because they ignore that leading 0. The options that we have for that are a 0 pay claim. Typically what it's going to be is a 1, an admit through discharge, or essentially a claim for the entire encounter, which is usually confined to a single date of service. So then we're going to go to the statement from and through date. For RHCs and for FQHCs, typically those two dates are going to be the same because the encounter is starting and ending on the same calendar day usually. For Medicare, Medicare wants a 6-digit date format in both of those fields. We'll see in a little bit that Medicaid for some of the states allows either 6 or 8. So since they allow both, it may make sense to just always put the 6-digit date format so that you're complying with both Medicare and Medicaid rules on the date format here. Okay, so then the patient name field, of course, is the patient we're seeing, right? So Medicare's instruction on the patient name is to enter it exactly the way it appears on the Medicare card. But then Missouri Medicaid says it has to be in last name, comma, first name, comma, middle initial format, which could be different. For example, if they don't have an initial on their Medicare card, that may be a difference between Medicare and Medicaid. Okay, so then we get into some information on the encounter type or the admission type. And here's where we start to get into some I guess, data dictionaries on indicators that go in the fields on the claim. So we've got another date field here that can be for the date of admission or date of encounter, and it can be 6-digit or 8-digit format. But one thing that's important in this admission block of data, if this were a hospital, for example, we may have the hour of admission, we may have the date of admission since we're spanning multiple days for an inpatient stay. But for RHCs and FQHCs, this last box, box 15, identifies the source of admission. So what Medicare says for source of admission is where the patient came from before presenting to the healthcare facility. So that's not a referral source. That's not like a physician or a hospital. It's where the patient presented from when they came into the FQHC. So was that the patient's home? Was it school, etc.? Now, Medicare, makes this a required field. Missouri Medicaid asks that we leave it blank. And I think that's important to keep in mind, where a lot of these claims may start with Medicare as primary and then cross over to Medicaid as secondary. We may end up having some issues or adjustments we have to make on the claim from primary to secondary to meet the Medicaid agency's specific billing requirements for those. So these are some of the admission source options that we can put in that field 15 on the UB04 claim form. So that the patient, we're looking at the outpatient definitions for RHCs and FQHCs. If we were a hospital submitting an inpatient facility claim, we would be looking at the definitions for inpatient facilities. So if the patient presented to this facility for outpatient services, which is probably the most common example for RHCs and FQHCs, that field 15 is probably going to have a 2 in it more often than not. And again, that's going to go right here in this field 15 of the claim form. But you can see there's lots of different options. This is just an excerpt of some of the most common ones from Medicare's manual of examples for RHCs and FQHCs that you may put in that field. So then just like the block of data relating to admission or the reason for visit, the date of the encounter for RHCs and FQHCs, there's also a block for discharge data, which is talking about the discharge disposition after the encounter. Where is the patient going? So this first block, 16, is usually the discharge hour. That's more important. That's not required for FQHCs and RHCs, since this same claim form is used for hospital inpatient services, skilled nursing facility services. That's where we may put the time of the patient's discharge, 0 through 23, representing the hour of discharge on a day. But for field 17, the discharge status, that is something that we use for RHCs and FQHCs. And that says not where the patient came from, not the source of admission, but then afterwards, where are they going? Where are we sending them after the encounter that they're having at the clinic? Often that's going to be a 0-1. So these are 2-digit codes. And we have to have the leading 0 there saying that the patient is going home or self-care. If, however, you're sending the patient to the hospital, if the patient left the visit against medical advice, is going to a hospital or critical access hospital, there are different discharge disposition or discharge status indicators that we would put in this field 17 to reflect where the patient's going. So then below the admission and discharge data blocks of the claim form, we have this row called condition codes. And condition codes are giving us more information about a patient's situation or circumstances. So for example, these are going to be 2-digit codes, and there's a huge dictionary of a bunch of different possible condition codes that we may put on the claim. I've pulled a few that I thought may be the most relevant to RHCs and FQHCs that you may consider putting in these condition codes. And we have, let's see, what is that, 10 different possibilities, and you don't have to fill all of them out. You may not even fill any of them out if there aren't any condition codes that describe a patient's situation. For example, if the patient's complaint or injury or diagnoses relate to an employment-related illness or injury, then we can put them as a 0-2, an employment-related accident or injury. If you'll remember back to a week or so ago when we were talking about the CMS 1500 claim form, if you were in that session, this is similar to the 1500 claim form. There's a box where you say yes or no if it's employment related, yes or no if it's accident or injury related. So this is how we indicate it on the UB04. If we have a patient who is under hospice care, and hospice care, of course, encompasses palliative treatment, not curative treatment for a patient's terminal illness or disease. But outside of hospice, there can be separate payment made if you are doing an evaluation or treatment of something not related to the patient's terminal condition. So if that's the circumstance, we have a patient that's under hospice care, but maybe has something acute, I don't know, bronchitis, sinusitis, something like that, where we are giving some evaluation and treatment for it, we put a 0-7 condition code on the claim, and that tells the payer or Medicare that we are entitled to separate payment outside of what is otherwise an all-inclusive hospice payment, and why we're asking for that separate payment. If we're doing a corrected claim, we may be indicating what we're correcting by adding a condition code. So we might say we're changing that, we're correcting the date of service, we're revising the revenue or HCPCS code on the claim. And in those instances, if we go back up to the bill type, that 4-digit bill type with a leading 0, a 7, a 1, or a 7, depending on whether you're an RHC or an FQHC, the 4th digit must be a 7. That's indicating a corrected claim if we're using condition code D2 on the UB04. And while I'm saying that, even more so, I think, than the CMS 1500 claim form that we were looking at a couple of weeks ago, on the UB04, there are a lot of examples of this where if this is used, these other fields must contain very certain data elements or have data requirements. We see a lot of very specific revenue codes, CPT code, modifier code combinations on the UB04 that may be required that I feel like are more specific than we sometimes see on the 1500 claim form. A code if we're changing the diagnosis codes on the claim, adding, exchanging, removing diagnosis codes on the claim. And then a couple that are important right now, there is a condition code for DR, disaster related. And this was important around this time last year. We had several Medicare interim final rules come out as part of the public health emergency, increasing flexibility for RHCs and FQHCs and nearly every other provider type. And because those rules or flexibilities were only as a result of the public health emergency, at the time, there were some specific billing requirements that we put condition code DR on the claim form to be paid for services that we otherwise would not have been paid for, but they were being billed as part of the disaster, the public health emergency. And then I mentioned with RHCs and FQHCs, where you typically get your single encounter, all-inclusive encounter rate for a data service, but there may be circumstances that you have distinct encounters on a particular day for the same patient. When that's the case, there are several things we're going to have to do on the claim, and one of those is to add a G0 condition code up here in one of these condition code fields to indicate that one of the services on the claim that we are billing is a distinct medical visit for the same patient on the same day. Without that, we're likely to get denied payment on that second item. For Missouri Medicaid specifically, there are a couple of condition codes you want to keep in mind. If you are providing a service, whether it's face-to-face or whether it's a service via telehealth, that is the early periodic screening or HCY covered benefits, there's a condition code as well as a modifier that we're going to add to the CPT or HCPCS code we'll look at in just a minute. And this condition code A1 has to be in this area of the claim form. And then if any family planning services were done during the encounter, then we're going to put the A4 condition code on the claim as well. And Missouri Medicaid has a rule that we can't commingle any services that involve family planning with other services on the same claim. So if you are providing family planning, you put the A4 condition code here on the claim. And anything that's not related to family planning will have to go on a separate UB04 claim form submission to Missouri Medicaid. Then there are something called value codes on the claim form. And the difference between these and condition codes is that condition codes I think of as describing circumstances, qualitative circumstances, where value codes are things that are quantifiable. And so what we do with value codes is we put 2 digits that explain a situation, but then we put a dollar amount that's associated with it. So for example, if we're doing a visit for auto liability or workers' comp insurance, we've got a code for indicating auto liability 14 or workers' comp 15 as example. And then we put the amounts that we are claiming as conditional payment pending the outcome of an auto liability or workers' compensation claim. And so we're claiming that as a conditional request for reimbursement because some other insurer has denied coverage. So we're billing Medicaid because those other sources of payment have not paid. And that's where we indicate the amount. So this is where we really get into some nuts and bolts of what services we're reporting for RHC and FQHCs to Medicare and to Medicaids or commercial payers, and a lot of specific combinations of bill type, condition code, revenue codes, HCPCS codes, and modifiers in order to simply get paid, and having to have a really precise combination of those data elements. So on the UB04 claim form, I've got on this slide just a single row where we would describe a service. There's 22 rows on the UB04 claim form to describe different services. And a lot of times if we've got a facility like a skilled nursing facility, home health agencies, hospital inpatient services, 22 lines isn't even enough. So we end up with multiple pages of a claim form describing all of the revenue codes and the HCPCS codes that have been provided. Now, I'm going to start kind of on the left here and work my way across. For item 42, that's a 3-digit revenue code, and revenue codes are like categories. So we have revenue codes for pharmaceuticals, revenue codes for supplies, revenue codes for medical services. And then we break that down further within that general category into HCPCS codes or CPT codes, the 5-digit codes that explain exactly what was provided. So in field 42, where we have the revenue code, whenever you as the RHC or FQHC are reporting an originating site fee for a telehealth service, we're going to put 078 as the revenue code. And then there's a description, and that's just describing what 078, what that revenue code is. So 43 is describing the revenue code. And then in 44, the HCPCS code that you will report is the same as other entities, the originating site fee Q3014. We'll have that with whatever date the telehealth service was provided, with a unit of 1, and your charges for the originating site fee, knowing that the actual payment you'll get is likely just going to be a fixed fee for originating sites. Here's where we also get into some really variation on how the state Medicaid agencies handle reporting things for RHCs and FQHCs. And we'll walk through quite a few examples of how their rules are different. For Missouri Medicaid, for example, they distinguish between a provider-based rural health clinic, so one that operates and functions like an outpatient department of a hospital, versus an independent rural health clinic. And they're going to have some different rules depending on what type of RHC you are. So if you are a provider-based RHC operating and functioning like an outpatient department of a hospital, and you provide multiple encounters to the same patient on the same day, where the encounters are distinct and separate, typically for different diagnoses, right? What Missouri Medicaid says is you're going to use row 1 to describe your first encounter, skip a row, and then after that on this, you'll have a second procedure row describing the second encounter. And I had to kind of chuckle when I'm reading these rules. It's kind of like, okay, 1, 2, skip a few. My kindergarten daughter came home reciting that the other day, and that's what I'm thinking of, like, all right, now skip this row and put something in line 3. And then we're going to have a total at the end of the billed charges for both encounters. And hold that thought too, because we're going to have some modifiers, 2-digit modifiers at the end of the HCPCS code that describes the encounter to indicate to Missouri Medicaid why or how we should be paid for that third row, the second encounter, in addition to the condition code that we have to have up at the top, indicating multiple procedures on the same day. Now, if you are billing to Missouri Medicaid and you are an independent rural health clinic providing multiple services to the same patient on the same day, what you do is report T1015. That's a HCPCS code that's going to go here in field 44. The units are 2, and that's telling Missouri Medicaid for independent RHCs that you've had 2 encounters for the patient on one day. You'll put up in the condition codes, I think it was E0 is the condition code describing multiple encounters for the same patient on the same day. And if you are an independent RHC, you have to attach a certificate of medical necessity to explain why or how the patient's having that second encounter. So when I send the slides out, that you'll have a link here that'll take you directly to Missouri Medicaid's certificate of medical necessity form that needs to be attached with the claim form itself. Oh, one other thing I wanted to add here. I need to move my, there we go. Move my little images. In the description field right here, oh, sorry, I'm looking at the wrong screen. Description field right here, 43. If you are an independent rural health clinic billing Missouri Medicaid, the description here is going to say rural health clinic visit. So they have a very specific item they want there. Okay, so now these are, I'm going to go back to that revenue code box. And these are revenue codes that Medicare lists in its provider manual as some common ones that you'll see for rural health clinics and for FQHCs. So these again are, I'm sorry, I think I said 3-digit before, 4-digit codes where the last digit may vary depending on the specific type of visit or service. So if the most common one is probably going to be a 0521, that's a clinic visit by a member to the RHC or to the FQHC. But there may be other types of revenue codes. That's the one that's often used for your all-inclusive rate that you're going to be billing for payers. For FQHC, though, you can use any valid revenue code. These are just examples. You can use any valid revenue code for the additional items and services that are being billed, with a few exceptions. So I won't read all of these, but one thing I may suggest, if you have the option to put like edits or alerts or errors into your billing system, you may have one that has logic, something like, if payer is Medicare, then don't allow these revenue codes on the claim because Medicare doesn't allow them to be billed for FQHCs. If the FQHC is billing for preventive services to Medicare, so those items and services that Medicare covers at no cost to the member and pays 100% with no deductible, co-insurance, etc., then the revenue code you'll use for those services is 0771. For RHCs, they generally, for Medicare, are not required to have revenue codes. The revenue codes are only required for medical or mental health visits when being billed to Medicare. And then both FQHCs and RHCs will use revenue code 0780 when they are billing the originating site fee for telehealth services. Okay, so I've got several slides here talking about the HCPCS or CPT codes that you're going to be billing Medicare, Medicaid, or other payers for. And I'm going to talk about Medicare rules and kind of walk through some of the state agency specific rules here where we start to really see some differences on how this is handled. So for Medicare, FQHCs report all of the HCPCS or the CPT codes for the services they're providing. The first line item is going to be the code for your all-inclusive rate, your encounter rate that you get paid for. You report everything else describing the actual services that you've provided. So that may be venipuncture or an EKG or an x-ray or whatever the service may be. Those subsequent line items are for data gathering purposes though, and don't, unless there's an exception that allows them to be paid separately, are generally not paid separately outside of the all-inclusive rate. Rural health clinics are not required to report HCPCS or CPT codes to Medicare. You can, you're just not required to unless it's a preventive service. I think it might be helpful, especially for a lot of patients that may have Medicare as primary and Medicaid as secondary because we're going to see some of Medicaid's HCPCS or CPT code billing requirements in just a moment. So what this looks like for Medicare is we're going to use the revenue code, depending on whether this is an RHC or whether this is an FQHC. And then the HCPCS codes are generally codes that start with the letter G to describe your FQHC or your RHC encounter for that all-inclusive rate. So we've got one for a new patient that pays slightly more than, or I guess I shouldn't say pays slightly more, distinguishes from the established patient visit. And a new patient, remember, is a patient who has not seen that provider or another provider of the exact same specialty in the same group practice in the last 3 years. So those are for medical visits. And then we have codes for FQHC mental health visits, because remember that medical and mental health visits can be paid together on the same day. Now, the CARES Act about this time last year expanded what RHCs and FQHCs were allowed to do when it came to telehealth, because generally, while they are allowed to serve as the originating site and to bill Q3014, the originating site fee for telehealth services, they had not, with Medicare, been allowed to serve as the distant site. Now, during the public health emergency, as a result of the CARES Act, RHCs and FQHCs can serve as the distant site providers. One thing I will put an asterisk on is that it's the way it's written in the CARES Act is through the end of the public health emergency. So we talked several weeks ago about changes that are relevant through the end of the public health emergency, some that are relevant depending on your state's emergency declarations, and some that are relevant through the end of the calendar year when the public health emergency ends. RHCs and FQHCs right now would lose their ability to serve as the distant site provider for telehealth services under the Medicare program when the federal public health emergency ends. So that's something we're going to want to keep an eye on as well. The HCPCS code that we're going to use when you're providing the distant site service is G2025. And what I've got a link to here is a list of those codes that are eligible to be billed as distant site telehealth services. And Medicare says that right now, while FQHCs and RHCs can serve as distant site telehealth providers, they can provide any of those services that are eligible for telehealth distant site and bill for those using G2025, not necessarily the HCPCS or CPT code that describes the actual service. So I will send these slides out, and the link that you'll get that you can follow is a spreadsheet that Medicare publishes of all of those codes and services that can be done via telehealth right now. So here's where we get into some really technical billing details. For FQHCs, this was through June of 2020. So since our timely filing period's a year, you're probably kind of at the end of this particular billing sequence. And then we'll have a different sequence from July 1st on. So for services through June 30th of last year, the way that you would bill for a telehealth service is to report the G code for your FQHC visit. Okay, so that's when we go back here to your normal FQHC encounter codes, right? So you report one of those on a line item. You then, on a separate line item, use a code that describes the telehealth service with a modifier 95. So that's where you click the link here and you look at an office visit. I don't know, I guess psychotherapy, any of the telehealth codes that are eligible to be done via telehealth with a modifier 95. 95 describes a telehealth service. Then you have a third line item with the distant site telehealth code for FQHCs and RHCs, also with a modifier 95. So we had 3 rows to be able to get paid the encounter rate and it as a telehealth service. If we were providing a telehealth service without an underlying, a qualifying FQHC visit, then we only report G2025 for the distant site telehealth service, and modifier 95 was optional. So the logic I kind of gathered in reporting modifier 95 here is distinguishing that that was done via telehealth in addition to your underlying qualifying FQHC visit. So this is what that looks like, and the difference for 2020 through June 30th, and then July 1st forward in billing for these FQHC telehealth services to Medicare. So through June 30th last year, we had those 3 rows, and we had the code for our qualifying visit, no modifiers, the code for the service we provided via telehealth, 95, G2025 saying we were the distant site provider of that service with a 95. And then the rule that went into effect July 1st that continues to be in effect so long as FQHCs can serve as distant site providers is a single row where we have the HCPCS code, and you can but are not required to add a modifier 95 to that. So still on the HCPCS code field, for Missouri Medicaid rural health clinics, okay, kind of switch gears in your brain now. If you are a provider-based rural health clinic, so you're operating as an outpatient department of a hospital, then you're going to use the HCPCS code that actually describes the service that you have provided in this field 44. So if that's an office visit, 99214. If you are an independent rural health clinic, then you're going to use a specific code here, T1015, and the services that comprise the visit that you're providing will be listed as the principal and other procedures further down on the claim form. If you are Oklahoma and you are an FQHC, we've got some kind of interesting instructions for you all. When you are billing a telehealth visit, it's T1015, so same code as Missouri. You're going to add a GT modifier, which is another telehealth service kind of modifier that Medicare did away with about 3 years ago, but Oklahoma Medicaid FQHCs will be using that for telehealth services. You'll have a second row where you describe the evaluation and management service that was provided, but you will not report the GT telehealth modifier on that second line item. So what happens when you do that is the first line item is going to pay, the second line item is going to deny. That's the rule unless the service that you've provided as a kind of telehealth service was a phone visit, because phone visits don't meet the face-to-face requirement for a qualifying FQHC visit. So the way you handle those is kind of the opposite. Line 1, the T1015 will deny. Then line 2, the code that you're going to report is the code for the phone visit, and that will pay at the fee for service rate for telephone visits. The phone visit line item will be billed with the GT modifier, which is the reverse. If it's any other evaluation service, GT goes on the first line. If it's a phone visit, it goes on the second line. Clear as mud, right? People wonder why we get claim denials and can't get paid. All right, so Oklahoma Medicaid rural health clinics. I'll have a link here where you can go to the billing manual for RHCs and how this works. Your revenue code in Oklahoma to Medicaid for RHCs is going to be 0521. So we looked at that. That's what it's going to be for most RHC visits, you'll have a procedure code describing the evaluation and management service that was provided. And when it's done via telehealth, you add a GT modifier to that code here in box 44. In order to be paid for phone calls for Oklahoma Medicaid rural health clinics, you have to have a separate fee-for-service provider ID number to get payment for those services and bill under that separate fee-for-service provider ID number. Okay, so now we're going to get into modifiers, which is still in this field 44. It goes at the end of the 5-digit HCPCS or CPT code. And for modifiers in field 44, we have got all kinds of things going on across the Medicare and the different state agencies. So try to follow along with me here, and of course, ask questions I can help clarify afterwards. It's about clear as mud. So for FQHCs, for Medicare, if you are billing two encounters because you've had a second distinct encounter on a single day for a patient, which right now can be done via telehealth, or it could be medical versus mental health services on the same day. The second line item is going to get billed with a modifier 59 in addition to the condition code. I think it was, I keep saying G0, I believe it was, up at the top of the claim to indicate that there was a distinct service on that calendar day for that patient. Oh, yep, there it is, G0. Then the HCPCS or the procedure code that you use on the line item is G0467 for that distinct separate visit. So there has to be an initial qualifying visit to have the distinct separate visit with modifier 59 and with G0 condition code. Kansas Medicaid handles that differently for FQHCs. So that exact same scenario of an FQHC billing for distinct services to a patient on a single calendar day, you're going to use it. The modifier you use or modifiers will depend on whether the two procedure codes, one for the initial encounter, one for the second encounter, are the same or if they're different. If they are different, you're going to use modifier 25. If they are the same procedure code, the second encounter is going to get a modifier 25, but also a modifier 76. 25 is a distinct and separate evaluation and management service on the same day as another procedure or service. Modifier 76 is a repeat procedure or service, and so that's why they want you to add 76 if you're billing the exact same procedure code twice in one day for the same patient. Then in combination with the G0 condition code, KMAP knows that you're indicating this benefit is a distinct and separate visit on the same day. Right, so for Medicare, rural health clinics typically would add a modifier. Well, this, I guess, went through June 30th, 2020. So if you still have any claims, we've got a short window here where you're within your 1-year timely filing period. During that time frame, rural health clinics that were billing for telehealth services, because that was an expanded benefit as part of the federal public health emergency, we're adding modifier CG, and CG is a disaster related modifier. And that's how RHCs were getting paid January through June of last year for distant site telehealth services. As of July 1st, you're no longer required to add the CG modifier to your rural health clinic claims. For G2025, that is our RHC, FQHC, distant telehealth distant site code. The CS modifier will be added to that code through the end of the COVID-19 public health emergency when the telehealth visit was to evaluate COVID-related symptoms, determine the need for a COVID test, or involve the administration of a COVID-19 test. What that modifier CS does is waive all coinsurance and cost sharing for the patient during the public health emergency. It can also be added for RHCs and FQHCs, providing preventive services via telehealth as the distant site provider. And by adding CS or cost sharing modifier, then that will signal to Medicare to process the claim at 100% rather than imposing cost sharing. Since we're not identifying the specific service, we're using a generic telehealth distant site service code, and that helps us get the cost sharing process correctly. Still on field 44, talking about modifiers. If you're billing to Missouri Medicaid and you're doing a telehealth service that is part of the EPSD screening, early periodic screening, then you still report T1015 as the procedure code. And if you're an independent RHC, adding the EP modifier, which you would normally report to your preventive medicine code if you were face-to-face with a patient, still goes on the claim for Missouri Medicaid, so they can process it as an early childhood periodic screening service. And then Oklahoma Medicaid. If you're an FQHC and you have multiple encounters on the same day, so we'll try to summarize this again. For Medicare, the second encounter gets a 59 modifier. For Kansas Medicaid, if you're using different procedure codes between the encounters, the second encounter gets a modifier 25. If you're using the same procedure codes for the two encounters, the second encounter gets a 25 and a 76. If you're Oklahoma Medicaid, for FQHCs, the second encounter gets a modifier XE, which is kind of like a modifier 59. Several years ago, Medicare expanded modifier 59 into 4 X modifiers: XE, XP, XS, XU, I believe, to describe different, distinct and separate services. So Oklahoma Medicaid is utilizing one of those more specific modifier 59 modifiers in that example. Now, with Oklahoma Medicaid, one thing you have to keep in mind too is that in order for those two encounters to be paid as multiple encounters rather than a single all-inclusive encounter rate for that day, the second encounter has to be associated with a different diagnosis than what was connected to the initial encounter. Okay, so now we're looking at charges. For FQHCs, when we have the standard revenue code 052, usually 1, line item, and we have our evaluation and management procedure code, then the total charges are going to be the total charges for all of the services during the encounter for Medicare. Because remember, with FQHCs, we have our encounter code, and then we report all of the individual services below that. We're not going to get paid for those individual services. It's reported for data gathering purposes, but the total charges for that FQHC encounter are the total for everything that's been done for the patient, minus any approved preventive services that are carved out and paid separately. For Missouri Medicaid rural health clinics, for the total charges, after you have all of your rows describing the procedures, the CPT codes and HCPCS codes on the claim, skip a row, and then you're going to enter revenue code 0001 to indicate that the row is a total charge row. And then over here in box 47 of that row, you're going to sum all of the charges for that visit and put it there. So here's an example of what that might look like for RHCs and FQHCs, and this is a Medicare example. So we may have our revenue code for RHCs where we don't have to report a procedure code. It could be blank, or we can report the HCPCS code if we want. I suggest doing that in case it crosses over to a secondary data service charges, but the charges do not include the charge for the preventive service. So the total charges here are $150. We do the same for FQHCs, except for the preventive code, revenue code, remember, is 0771 for FQHCs, and it's still carved out separately. All right, so there are a couple of service-specific billing instructions when we're doing this for telehealth for RHCs and FQHCs. If you're providing what's called the Welcome to Medicare or the initial preventive physical exam for Medicare beneficiaries, the HCPCS code for that is G0402. And FQHCs can be paid for that service if it's done as a standalone service for the visit. But if it's done on the same day as another qualifying visit, you will not be paid separately for the Welcome to Medicare service. It's going to be part of your all-inclusive rate for your qualifying visit. The next couple of bullets are not your traditional Medicare telehealth services, but I think of them kind of in a similar category or bucket. They're care management services, and they're not necessarily face-to-face services. So communication technology-based services are what are called virtual check-ins, where you, through virtual communication technology, check with the patient, or the patient checks with you to see if they need to have a face-to-face or a telehealth service, or if it's something that we can handle without requiring a visit. Or remote evaluations, those can be done through pictures or through video. So I might send my kid's pediatrician a picture of a rash, and do we need to come in, and they can give me guidance. So what we're going to do for both of those categories for RHCs and FQHCs to Medicare, when we do either a virtual check-in or a remote evaluation by photo or video, is report G0071 as the procedure code in field 44 of the claim. We don't have to use the CG modifier, so that is the telehealth modifier, and it's going to be paid on a fee-for-service basis based on the physician fee schedule. Care management has its own procedure code that we're going to report. And again, RHCs do not have to use the CG modifier for that service, although both RHCs and FQHCs can be paid by Medicare for general care management. I know we have quite a few providers in the group that do behavioral health services, and we could probably have a whole session dedicated to this topic. But just like there are medical chronic care management codes payable by Medicare, there's also psychiatric collaborative care, which is designed for preventive care type settings, including RHCs and FQHCs, who are collaborating with behavioral health providers who can help with mental and behavioral health medications specifically for patients. So RHCs and FQHCs can provide and bill for that service as well. Same things for Medicare annual wellness visits, that they can be billed as a standalone service in the absence of a qualifying FQHC visit. Got, I think, 2 slides in 2 minutes, so we'll see how quickly I can cover these last couple of things here. The diagnosis fields look very similar as they do on the CMS 1500 form, and right up here in this field 66, on this example, they put a 9, and that would indicate that we're using ICD-9 CM codes. This would be a 0 for the vast majority of your services now, where we're reporting ICD-10 CM codes. And then field 67, where it's kind of shaded out here, that represents the principal or the first listed diagnosis code. And that's really important that you know and understand what how the principal or first listed diagnosis is defined under official guidelines for coding and reporting. And for Missouri Medicaid, for example, if you are reporting the early periodic screening services, there are certain diagnosis codes that if they are reported on the claim, and if we are adding an EP modifier to the service as an early periodic screening service, that one of these diagnosis codes has to be in field 67 for the claim to process correctly. And then A through Q are other diagnoses that are relevant, that the patient was diagnosed with, and that were treated during that visit. So we defer to official guidelines for coding and reporting for what diagnosis codes go there and in what order. And then just one other kind of Missouri Medicaid specific rule, if you're doing any family planning, which remember has to be on a separate claim from non-family planning services, there's a list of certain diagnosis codes that have to go in that field 67 as the principal diagnosis on the claim. All right, so as you can tell, there are a lot of hyper-specific combinations of condition code, revenue code, procedure code, and modifiers to get the billing right for RHCs and FQHCs. And the rules can even be different between Medicare and then some of your secondary payers. So I hope that gives you an idea of some of the more common indicators and services that you may provide. I see we've got a couple of comments too. I'm happy to review those and send in responses to any specific questions you have. And of course, you're always welcome to use the HTRC email address to get questions answered as well.
Sorry, I was responding. I want to thank everybody for coming today. And the two suggestions that were in the chat we'll look at. I think those are both very good for future sessions. In addition, if you have any other topics that you'd like us to consider, and certainly other questions, you're always, please email us at the HTRC email address. And Christy, I apologize, but could you tell me what that is again? I always forget it.
No problem. It's HTRC@kumc.edu. I'll also put it in the chat for you.
Great, thank you. And I hope everyone has a great day, and we will see you in the next sessions we have planned. And the next two will be in June, correct, Christy?
That's right. Our next session is Thursday, June 10th, and it will focus on quasi-telehealth services like e-visits, virtual check-ins, and remote reviews. So we'll see you then on Thursday, June 10th at noon.
Thank you. We look forward to seeing everyone, and have a great day and a great weekend.